Hi from Boston. My name is Emilio Madrigal. Today is August 25th, 2020, and I am joined remotely by my good friend and colleague Rafat Manan, who is in Philadelphia. Today we continue our GYN pathology series. This is actually lecture number 5, and it's going to be delivered by Dr. Matt Quick, who is an associate professor of pathology at the University of Arkansas for Medical Sciences. Dr. Quick's lecture is titled Endometrial Adenocarcinoma, Challenging Differentials. As always, you can post your questions and comments in the Facebook and YouTube chat windows, and Rafat and I will make sure to pass those questions and comments along to Dr. Quick at the end of the lecture. So with that introduction, I'll just pass over the microphone to Dr. Quick.
All right, thank you for that introduction. Today, this morning, I would like to thank the Pathcast team for allowing me the honor of talking to everybody out there. We're going to talk about endometrial carcinoma, and I do realize it is somewhat early in the morning, so I thought I might take a slightly more light approach to this lecture, and instead of just bombarding you with big lists of differential diagnoses, I would give you 6 things that I want you to remember. And I'm going to present them to you in the format of 6, I think, what I would call instructive cases, but hopefully you'll find them that way as well. And so with that, we'll go ahead and get started with case 1. So this case is a 46-year-old with an endometrial polyp. And when you look at the histology, you can see these huge chunks of tissue. Now, this is becoming much more common as we have more MyoSure procedures. And we're starting to see these somewhat more generous samples, right? And immediately when you look at the image on the left, you should be a little bit worried, right? There's some glandular crowding. You might see some squamous morioles. And then when you look at the image on the right, that worry should intensify. And it's because that lower fragment of tissue has an abundant smooth muscle stroma, and you see these angulated glands within it. And granted, this is a very generous sample. And so you may think, well, gosh, this could be invasion. And if you were anything like me, you were told when you were a trainee that you should never diagnose invasion on an endometrial biopsy, or at least that's what I was told. And you know what? I think that that's probably a good idea because entities like this out there can ruin your day. And so this is not invasion in an endometrial carcinoma, but it does look like it. And so the first takeaway message that I want you to have, we got right to it, didn't we? Is that when you look at an endometrial biopsy and all of a sudden something looks invasive to you, I want you to back up and consider the atypical polypoid adenomyoma for a moment. And this entity is often not thought of. We tend to forget about it and ignore it. But it can certainly lead you down the rosy path if you look at an endometrial biopsy and start to think that you're going to call invasion on it. So what does an atypical polypoid adenomyoma look like? Well, they can be sessile polyps. They usually are these sessile polyps, which means they kind of raise up off the endometrial surface, although they may be pedunculated. Some of them are even endophytic, and I do realize that that makes them atypical endophytic adenomyomas or atypical adenomyomas and not at all a polypoid adenomyoma, but they can have that configuration, so just keep that in mind. What they will consist of is a nodular mass of smooth muscle-like stroma and glands. And these glands tend to be irregularly distributed and angulated. So the first thing you're going to see is something that looks invasive. It's not uncommon for those glands to be atypical, and there may be a variable amount of squamous morioles. The important thing to remember about these is, although they're not exactly equivalent, you should think of them as equivalent to EIN or atypical hyperplasia. These guys are frequently associated with endometrial adenocarcinoma, so you have to be on guard for them. The patient in general is going to require surgery if you make this diagnosis, so you have to take it seriously. They do contain many of the same mutations that we see with traditional endometrioid adenocarcinomas, so they are neoplasms, and they must come out. So here's what I would call an infiltrative appearing APA, but you can see this tumor. The glands are not that crowded. They have not started to melt together and form cribriform structures. They're still singly dispersed, but they're angulated and they have kind of a haphazard arrangement. And if you're into pattern-based recognition like many surgical pathologists, you'll look at this and you'll think, gee, I really want to call invasion on this, but I'm telling you, you actually shouldn't. Again, this example here, you can see that there's a little minute small glands just kind of percolating through the center of this image, and they're angulated as well, again, looking like they are invasive. Now, this example has some morials in it, and morials are one of the more helpful features that you can see in an atypical polypoid adenomyoma. When you talk about morials, it's important to realize that they come in many shapes and sizes and flavors. And so here's two examples of morials, and there's many more out there, but I just want to give you kind of the more common looks that you'll see with this. They may be what we call immature morials, which we see on the left in the yellow circles. And they may be more of the mature or keratinizing morials on the right. And I think everybody recognizes those fairly easily. So the ones on the left, the immature ones, are the ones we want to think about for a minute. How will you know that you're dealing with these? Well, they'll have the tendency to look like solid tumors. So you may think, well, I should probably increase the FIGO grade in this invasive looking endometrial biopsy, which again, don't do either of those two things. But you'll look at those morials and you'll notice that they kind of swirl or they whirl and they almost look like a school of fish kind of streaming along. And it's so that swirly whirly pattern of kind of round aggregates within the glands is going to be something that you want to look for in your immature morials. Just a little note, don't think that you can stain these guys for P63. They don't stain with P63 in the same manner that you would expect them to. They actually will stain with beta-catenin in a nuclear pattern, but that's a completely different story that we're not going to get into right now. Another thing to remember is that these atypical polypoid adenomyomas are frequently associated with low-grade adenocarcinoma. Some papers cite that on the order of about 40% or so. So don't be surprised if you see atypical polypoid adenomyoma and adenocarcinoma in the same sample. Here you can see the adenocarcinoma on the bottom and the atypical polypoid adenomyoma on the top. I think one important thing to remember here is that we all see way more atypical polypoid adenomyomas than we know, but we usually just see them as endometrial cancers. So next time you're looking at a hysterectomy with an endometrioid adenocarcinoma and it's got a lot of squamous morials in it, look around and see if you can find maybe the precursor APA that it came from. It's a great way to kind of see these guys in their normal histology. So the differential diagnosis for these APAs, well, it includes other things that are epithelial and stromal, right? And so EIN, atypical hyperplasia, one thing about that is it's going to lack that smooth muscle stroma. And that smooth muscle stroma is important because that's what actually gets you to think about invasive carcinoma. So again, it's going to lack that stroma. Typically, the glands are going to be more crowded, although that's not always true. I have to say that true myoinvasive carcinoma is in the differential diagnosis. And if it's there, there is not a good way to tell those two apart. It's virtually indistinguishable. That being said, it's still a risky diagnosis to make on biopsy. I would probably be more descriptive in my diagnosis and use a comment. And then finally, there's also regular adenomyomas, not atypical ones, but regular adenomyomas and adenomyomatous polyps. These usually lack the same kind of fibromuscular stroma, and they'll have way less glands with less epithelial atypia. And they're also quite uncommon. So if you think that you're looking at an adenomyoma or a polypoid adenomyoma, I would seriously reconsider that. And although that may be the case, I would think about other things first. So that is our first case. And the take home is don't forget about your APAs. Now, second case, learning point number 2. We have a 60-year-old patient. She had postmenopausal bleeding. And this is what the sample looked like. And so at low power, you will see that this is a very complex epithelial proliferation of glands. It does have a papillary configuration. You'll notice that there's lots of kind of clusters of cells within the lumen of some of these glands, very discohesive looking, scattered inflammatory cells. And when you go down to higher power and you take a look, there is some nuclear atypia. And I'm not going to say that this is what I would call severe nuclear atypia, but it's definitely at least moderate, right? And there's some hyperchromasia, you've got some prominent nucleoli, and this could be worrisome. And so what I'm going to say now, I hope that some of my GynPath friends out there are not listening too closely, or maybe they haven't had their coffee yet. But what I'm going to tell everybody now is that when you see a biopsy like this, you have to forget FIGO grading. And now, please don't quote me on that. Keep this in context. I don't mean forget FIGO grading altogether. But what I mean in this case is that we're not ready to FIGO grade this tumor yet. And so if you're ever looking at a biopsy and you appreciate what you would say is moderate to severe nuclear atypia, and it's scattered all throughout the biopsy, do not just say, well, we're going to call this endometrioid carcinoma and we're going to bump the FIGO grade, right? And that's what I mean by forget FIGO grading. I don't want you to bump to FIGO grade 2 based on nuclear atypia unless you have ruled out serous carcinoma, because there are variants that look very, very similar. And I've seen this mistake made time and time again, where an endometrioid carcinoma is quote unquote bumped and it turns out to be serous. And this is important because a missed diagnosis in this area really alters the planning for the subsequent surgery, as serous carcinoma is often going to be accompanied by a complete staging procedure, whereas a grade 2 endometrioid carcinoma might just have a total abdominal hysterectomy, maybe some nodes, and the tubes and ovaries are going to come out, but they'll usually leave the omentum behind. And so if we go back to that case that I just showed you, here's the P16 and the P53. And what this case was an endometrioid carcinoma with small non-villous papillae, which is one of the morphologic variants of endometrioid carcinoma. The P16 here shows the traditional kind of patchy, albeit focally strong staining pattern that you can see. I still call this negative because I don't want people to look at this and think that I'm calling that positive. That's patchy. It is not at all indicative of a serous carcinoma. And then on the right, you can see that the P53 has very, very weak to focally not so weak nuclear staining, and we call that wild type P53 staining. So this is not a mutant phenotype. So this should make you feel much more comfortable saying, okay, you know what, this is probably just one of those scary looking variants of endometrioid carcinoma. And that's actually what I would just call a grade 1 endometrioid carcinoma. And this problem happens a lot. And here's two examples from two cases that I've had. And I looked at both of these examples, and I would ask you to look at them as well. And the one on the left and one on the right, one of these two is serous carcinoma. And I'm not going to lie, when I look at this PowerPoint slide, I often have to remind myself which is which. So these are examples of the cases that I would say have more than enough nuclear atypia to make you pause, make you not bump, and make you do your stains first. And when you do that and you look at the P53, in this one, you'll see on the left, that case was a grade 2 endometrioid carcinoma. Yes, I did bump it because, well, I did the stain, so I obviously thought it was atypical. But it's wild type P53. So that's endometrioid. On the right, however, you have a null phenotype, and every single cell in there is negative, except for maybe some of the scattered inflammatory cells. So I would call that a high-grade serous carcinoma. And so that kind of does bring up the point of, well, how do we interpret these P53 stains? Again, remember, if you're ever considering bumping your FIGO grade, get a P53 first. And there's three patterns that you're looking for. First is the positive pattern, or the mutant phenotype, and that's going to be strong diffuse nuclear positivity in greater than 75% of the cells. Now, there's no consensus on this. There's a lot of articles that will use different cutoffs. I like 75%. Dr. Gilks and his group had a great article about P53 staining and standardization that I think everybody should be aware of and read, especially if you look at a lot of P53 stains. That being said, 75%, it doesn't happen that often. Most of the time, as you guys know, it's 90% plus, maybe even 100%. The next pattern is null, and that will be nearly absent nuclear staining in all tumor cells. And then finally, the third pattern, and this one is somewhat uncommon, and that's what I would call the diffuse cytoplasmic positive pattern. This one is rare. You'll see nuclear and cytoplasmic positivity. And so when you see this one, and here's a nice example of it, that was shared with me. It almost looks like a P16 stain, and that's kind of the same staining pattern that you're looking for. You should see nuclear and cytoplasmic positivity. Sometimes it's just cytoplasmic, though. And so if you do see cytoplasmic P53 staining, that's not just funny staining, that's actually a mutant case, and you should hold that to the same standard as null or mutant staining with P53. So there are 3 patterns that you need to be aware of and keep those in mind when you're looking at these cases. And so that's learning point number 2. Keep in mind your nuclear atypia on small biopsies. Case 3. Here we have a 32-year-old with morbid obesity and abnormal uterine bleeding. And this case is tough because of a few things. The first one is her age. She's 32 years old, and I'm about to show you something that's maybe a cancer in the differential diagnosis. So already you should be a little bit worried because we don't like to diagnose carcinoma in patients that are that young. And sure enough, when you look at the sample, you see this. And so if you look at this sample, you would say, oh, well, there's some crowded glands, there's maybe some cribriforming, labyrinthine glandular architecture. You can see kind of a normal gland down in the bottom left, and it's being completely encircled by all these atypical glands. And you may look at this and say, well, that's, at least atypical hyperplasia, but maybe this is a carcinoma. And what if I told you that this was the only area in her biopsy that was atypical? And that brings up a really sticky situation. And that sticky situation is when to diagnose carcinoma, right? And so more specifically, when do you diagnose focal adenocarcinoma? And this is something that I consider very subjective and personal. And I know there's a lot of pathologists out there that would agree with me. Everybody kind of has their own internal thresholds for what they consider crossing the line to carcinoma and what they consider atypical hyperplasia or EIN. I'm not here to change anyone's mind. I'm mainly here to just tell you that, everybody struggles with this and we should all feel okay about it, the way that we handle it, as long as we handle it consistently. And I think the most important thing to do is to handle it consistently. So your surgeons and your clinicians know what to do when you write these comments that I'm about to show you. Now, from the textbooks and from the articles, sometimes it seems a little bit more black and white. You'll say, oh, well, in the textbooks, they say, oh, if there's loss of individual glandular integrity or if there's myoinvasion, you call carcinoma. But like I said, in a biopsy, you can't always tell if there's myoinvasion. Now, just for example, this is what I would call loss of glandular integrity, and that's an example of cribriforming. And so what do I mean by that? Well, I mean when one gland melts with another gland and becomes multiple glands. And so you no longer have individual glands. And I think the big controversy that happens here is when is there enough loss of glandular integrity to warrant upgrading a EIN or an atypical hyperplasia to an adenocarcinoma? And so these patterns that will invoke this are solid growth or cribriforming, maze-like glands, or kind of polygonal glands with thread-like stroma, or the mosaic pattern as it's called. And in the past, there have been suggestive measurements. I'm not a guy that likes to pull out a ruler every time I diagnose adenocarcinoma. I have my own internal thresholds that I use, as I'm sure many of you do. But there are hard numbers floating around out there that have been reported on before in the past. And sometimes these numbers are referenced and sometimes people use them. And I'm not saying that that's a right or wrong thing to do. But know that there are numbers floating around out there for this. And so it doesn't just mean if you see one cribriform gland, you can call carcinoma. In fact, I would argue that that's not the case. So these are patterns. I'm not saying that any of these are specifically carcinoma, but these are patterns that could make you think that. And so cribriforming, as you've seen before. And then, of course, maze-like glands. That's one of my favorite because what that is, if you look at the top left of that picture, that's actually intraglandular papillary growth. And to me, intraglandular papillary growth is atypical. And should be considered atypical. And so if I see larger areas of maze-like glandular growth where you can take your finger and you can trace along the lumen of the gland and it makes kind of like a maze like you'd have on those kids menus at Denny's, then you should think about adenocarcinoma. Mosaic-like glands, that's a tougher one to kind of pin down, but basically if your glands press together so much, like this bottom right image, where they start to mold around each other and you have these little threads of endometrial stroma, but really it's only 1 to 2 cells thick. If that is a large enough area, about 2 millimeters or so, that I do think is enough to kind of push someone to a diagnosis of endometrioid carcinoma. So, how do you handle cases like that? Well, that's tough. I think really it depends on the culture and the practice in which a person works. There are a couple of ways to approach this. You could be in the more conservative side of it, and you could say things like at least endometrioid intraepithelial neoplasia or atypical hyperplasia, whichever you prefer. And then you give a comment and you say that there's areas that border on low grade adenocarcinoma and that they need to follow this patient. Or alternatively, you could take a more aggressive stance and you could say that there's focal endometrioid carcinoma in a background of EIN or atypical hyperplasia. And then you give a comment telling why you think that. Now, this bottom diagnosis, I like to add in a background of EIN or atypical hyperplasia. Personally, if I make that diagnosis, and I do make both of these depending on what mood I'm in. I know I said consistency, but I'm consistent about my inconsistency, so I think that counts. But anyway, if I make that bottom diagnosis, one reason I talk about that background is when I get the hysterectomy specimen, and if I'm having a hard time finding adenocarcinoma, and I go back and look at the biopsy and I said it was focal, maybe I don't feel so bad. I still put in the entire endometrium to look and make sure there's nothing there. But a focal adenocarcinoma is a focal adenocarcinoma, and sometimes they are cured by biopsy. And so that helps me remind my future self that I might not see adenocarcinoma in the hysterectomy specimen if I get it. So I like to add as much information as possible when I'm being descriptive like this. So that is the third case. And I don't know if I taught you anything there, probably not, but at least maybe you feel better when you get these cases with focal adenocarcinoma. Now it's going to start to get real for a little bit. And this is a hysterectomy on a 55-year-old patient. The previous pathologist, which was me, called it high-grade Mullerian carcinoma on review of the outside material. And you're going to see why in a minute, because well, there's the tumor. And you look at this tumor and you say, well, gee, this could be pretty much anything. And I think that's the problem. When you look at this on the left, you have some kind of more rounded nuclei with kind of vesicular chromatin, a few micronucleoli in there. But on the right, this tumor starts to display some pretty severe nuclear atypia. It almost looks like right in the middle there, someone took a blast out of a blood smear and just plopped it right into the middle of this uh, sample. You got atypical mitotic figures everywhere, tons of infiltrating lymphocytes, but this tumor is solid, doesn't really display any defining features. And then, if you continue to look around, you see these large blood vessels and then more of this tumor with small possible glandular spaces starting to form. So you might think, oh, this is an adenocarcinoma, but I can't rule out serous carcinoma. And there's actually so much nuclear atypia, things like carcinosarcoma and undifferentiated carcinoma should kind of creep into your differential diagnosis as well. And so the problem here that we're going to attack is the nondescript high-grade solid carcinoma. And so how do you work up these high-grade tumors? And in some cases, you can't even really say carcinoma because you don't even know if it's a carcinoma at this point, right? There's some steps that I follow, and I think as long as you remember these steps and remember some of these panels that we're going to talk about, these tumors can be a lot less intimidating, and it gives you a framework for attacking them every time you see them. So the first thing I do is I scour the case histologically. And I look for anything that I can call a classic histologic feature. And this may mean putting in more sections. And this isn't, I know as a resident, I hated going back to the bucket. But let me tell you, in a case like this is not a knock on your grossing. This is my inability to diagnose this tumor histologically. So let's see if we can find something, right? Maybe we can find some traditional carcinoma hanging out in the background that we didn't get yet. And that could help. And then I'm going to start with an initial stain panel, and that's usually going to be kind of restricted, but I'm going to do things like pan-keratins, P10s, P53s, looking for traditional endometrial cancers like endometrioid, clear cell, serous, things like that. I'm going to show the case to my friends because they'll often give me ideas that I didn't consider because I just get lost in the forest on cases like this. And then finally, if our stains don't work, I'm going to order some more. And my extended panels usually consist of things like ERPR, napsin, CK818, and that's when we're kind of starting to think about undiff, D-diff, and clear cell carcinoma. And so this panel, the stains that are in gold, I think are kind of my favorite stains. To me, they tend to be the most predictive. P10's great because if it's lost, you're probably looking at an endometrioid carcinoma and probably not a serous because P10 is just not lost, rarely if at all, in serous carcinoma. P53, it's not that you can definitely have P53 mutant phenotypes in endometrioid cancers, cancers, clear cell cancers, serous cancers. So mutant doesn't help, but if it's wild type, then it does help to argue against serous carcinoma, as the vast majority of those are mutant. ARID1A, if you have access to it, argues against serous, more for clear cell. If it's MMR deficient, that's actually going to point towards endometrioid and undiff, D-diff, and away from serous. P16, I know a lot of people like P16. I don't like P16. I hate P16 because I believe that it can be greatly increased in any case that's proliferating rapidly, which these tumors by default do. However, if it's strong and diffuse, nuclear and cytoplasmic, it could be a serous. And of course, pancreatin, if it's strongly positive, it's probably not undifferentiated carcinoma. Napsin is great in clear cell. It's not so good if the tumor you're looking at has a vacuolated morphology, as there may be false positive staining, and you can just have some rare staining in any other endometrial cancer as well. So you got to be careful with napsin. One thing that I like to do is hormonal markers when I'm considering a clear cell diagnosis, as most clear cell carcinomas are just very weak to negative for ER and PR, whereas endometrioids tend not to be. And then finally, CK818 is great for finding the rare positive cells in undifferentiated carcinoma, even more so than pan-cytokeratin. So always remember that stain. So if we go back to the case that I just showed you a while back, and you look at the P53 stain and the P16 stain, you'll see why I don't like P16 as much as I like other stains. The P53 is, well, for lack of a better term, not that helpful. I would tend to call this maybe increased wild type, but how can I differentiate this from a low-level mutant? And this is a really tough P53 stain. It's almost to the point where I would say it's equivocal and not very contributory to the case overall. Fortunately, that's why we do stains in a panel. P16, well, what do you know? Strong diffuse positivity in a rapidly proliferating tumor should be no surprise. However, if you look at your extended panel, you'll notice that there's a lot of ER, a lot of PR, and that MSH6 is lost. And so if MSH6 is lost, that it means MSH2 is lost, and you have a mismatch repair deficient tumor, which is not that common in serous carcinoma. And finally, P10 staining is lost as well. And if P10 staining is lost, then you're probably dealing with an endometrioid carcinoma. So our morphologic differential diagnosis in this case was a grade 3 endometrioid, at least in my opinion, versus a serous carcinoma. And when you looked at the immunohistochemistry, the P53 didn't really help. Plus, you can't rule out endometrioid or grade 3 endometrioid with the mutant P53 anyway. P16 didn't help, but P10 and MSH6 really came through here. Both of those stains really favor an endometrioid carcinoma. So the final diagnosis in this case, in my opinion, would be a grade 3 endometrioid carcinoma. It just happened to be a really ugly and really solid one. So that's your take home there for case 4, is always have a good panel of stains to help you out. Do not rely on single stains to make your diagnosis. This next case, and I will never forget this one, a 68-year-old with postmenopausal bleeding. She had a dilation and curettage, and there was an endometrial polyp. As you can see, kind of the traditional polypoid glands on the top left. You've got that nice fibrous stroma. And then in the middle, there is a markedly atypical proliferation of glands kind of spreading around in between. And if you look at this immediately, and I know some of you out there thinking well, this just looks like serous carcinoma. And yeah, absolutely. This looks just like a serous carcinoma growing in an atrophic polyp, just like we're told that it's supposed to do. And if you look around, I think that the histologic features only support that, right? You got severe nuclear atypia. You kind of have that polygonal cell with a lot of eosinophilic cytoplasm. It seems to be shedding into the lumen, as serous carcinomas are wont to do. And you also have what looks like a lymphovascular space invasion in the stroma down at the bottom of this image. And these are all things that we're told that polyps with serous carcinoma can do and to look out for. So, right, pretty open and shut case. And so there were some, I traditionally do some stains on the front end just to verify these things, because once bitten, twice shy, right? And so I do my immunostains and I'm getting my panel and I look at this and the P53 is wild type, which gave me great pause. P16, yeah, I did it. I'm not proud of it, but I did do it. And look, it's negative. And then I did a PAX8 and it was negative as well, which led to a big fat question mark, because what I have here is an endometrial polyp with a very atypical tumor in it. And I'm told that these things are supposed to be serous carcinomas. So I had to reassess, right? Am I going to call this a serous carcinoma, this P53 negative? No, I'm not. So I dug around a little bit. Long and short of it is TTF1 was diffusely positive. Now we're going to circle back around to this, but you should be thinking about other things at this point. So where does this leave us? Well, just as I said before, wild type P53 staining has essentially ruled out serous carcinoma in this case. And I know how tempting that histology is to want to call that, but that's just not going to help us here. P16, again, highly variable. So I don't use it in isolation to diagnose serous carcinoma ever. I think it's best used in small samples where you're looking at a possible P53 null tumor. It's nice because it will be brightly positive and help you identify those tumor cells. Now, TTF1, and if you're a skeptic out there, which I'm a skeptic myself, you're like, well, come on, quick. I know that TTF1 can be positive in some endometrioid carcinomas and endometrial carcinomas. And serous carcinoma and clear cell carcinoma and even mesonephric like adenocarcinomas can be TTF1 positive. So that doesn't really tell us anything. And you're right, it absolutely doesn't. TTF1 actually for a while was thought to be a negative prognostic indicator when you see it in some of these tumors, as you can see by the percentages there. So it can actually be positive in about 10%, 11% of high-grade endometrioid carcinomas, which is not insignificant. So don't forget that. But this is an example, and a very sneaky example at that, of an endometrial metastasis. And so features that should make you think about an endometrial metastasis is when your patterns don't match normal endometrial tumors. And you would say, well, you know what? This is in an atrophic endometrial polyp. That does match, except one thing. This tumor is growing from an epicenter. And if you look at this image, you can see that it's displacing the glands outward. It's growing around normal structures. And it seems to be focused on one epicenter within this polyp. And I didn't catch that on the histology before, but I'm glad that my stains did. Tissue that looks out of place, that can often be a sign that you're dealing with a metastasis. Again, like I said, if there's a stromal pattern of growth, in other words, if the tumor seems to be limited to the stroma only, doesn't seem to be involving the glands around it, and is growing in around glands, you should be worried. Another feature would be extensive lymphovascular space invasion, especially when it's out of proportion to the amount of tumor that you have. Now, in this case, I don't think that that was really the case. I think that there's just a little bit of LVI, and you can certainly see that in a small serous carcinoma and a polyp. So this case, that wasn't that helpful. Dilation of the lymphatic spaces, and to me, that's kind of a plumbing problem. You can see that when there's a lot of plugging by tumor emboli, the lymphatic spaces will start to dilate. And then, of course, probably one of the most helpful features would be history of a previous malignancy. Just look in the chart, because sometimes the answer is right there in front of you. So just some histologic examples. These are some great examples of lymphatic plugging and dilation. Whenever you see lymphatic dilation, even if it's not a metastasis, I always want you to go back and find the tumor that's causing the lymphatic dilation. The lymphatics should normally not be that open. They should be somewhat collapsed. So if you're starting to see them swell up, whether it's in the myometrium or it's in a lymph node sinus, I want you to think, gee, I wonder what's causing this backflow issue that we're having. I bet there's a tumor emboli somewhere that I can find. And often if you look around enough or put in some sections, you're going to find those tumor emboli. And then you can see little fragments of tumor cell emboli on the right there within those lymphatics. When we talk about normal epithelium that's out of place, here's an example of a metastasis to the endometrium with a great stromal growth pattern. This looks almost like a stromal neoplasm, in fact. This was a metastatic melanoma, but you could see little strips of atrophic endometrium that had just been stripped off of the tissue and were floating around in this sample. And so that normal endometrium in the background would say, well, gee, you probably should think that maybe the endometrium is normal and something else is causing this mass lesion. And again, this is when you would want to think about a metastasis. Now, when you think about the differential diagnosis here, is very broad. I mean, anything can metastasize to the uterus, to the endometrium, and you're going to find case reports of all of these things metastasizing. But if you're going to go for most commons, the most common of the most common is just upper genital tract metastasis, and that's usually going to be your serous carcinomas, both low and high grade. And this is kind of more of a gravity issue, right? The tumor cells will break off from their tubal origin, or well, wherever their origin is, but probably tubal, right? They'll float down the fallopian tube, they'll implant on the endometrium, and they'll start to grow because serous tumors can grow pretty much anywhere they land. So if you see bland cells and Samoma bodies, you've got to think of an upper genital tract metastasis from a low-grade serous carcinoma. If you're seeing very high-grade nuclear atypia, I would make sure you rule out a serous. And now here, stains aren't going to help you localize it, really. There is WT1, which is negative in most endometrial primaries and positive in most tubo-ovarian primaries. However, there are endometrial cases that are positive for WT1, so you can't ever be too definite in your diagnosis, right? And you can just say, well, this is probably an endometrial primary because WT1 is negative. But just know that you can never trust one immunostain 100%. Breast carcinoma loves to metastasize to the endometrium. The most common variant that I see there is going to be the lobular variant, and they'll have that single file infiltrating appearance that you know that lobular carcinoma likes to present as. And then melanoma, so large plasmacytoid cells, they're going to be discohesive as well. Really should make you think of an undifferentiated, dedifferentiated carcinoma or a sarcoma, because it will have that kind of stromal growth pattern and it will look very tempting for a sarcoma. So I guess the more appropriate clinical presentation that I could have given you on this case, if I was being completely clear and forthright, would have been a 68-year-old with abnormal uterine bleeding and 3 lung nodules on her CT scan, which I did find out after I went back and did the chart review, which is why I got the TTF1, and this ended up being a metastatic lung adenocarcinoma. So again, just a cautionary tale to if your stains are telling you something and your pattern's not quite right, think about a metastasis, especially in the case of a high-grade carcinoma. Finally, case 6, and this is kind of the king or queen of all differentials here, is what we're about to talk about. And that's going to be a 58-year-old with vaginal bleeding to anemia. And so we get the case and I take a look at it and, oh, this is nice and easy. This looks like a low-grade endometrioid carcinoma. Granted, there's a little necrosis, but this isn't too bad. And then, oh, what is this? And you keep looking around, and then you kind of wish you hadn't, because now you start to find these solid areas of growth directly adjacent to the grade 1 endometrioid adenocarcinoma. And the longer you practice pathology, especially if you see a lot of endometrial samples, the more common this is going to become for you. You're going to find solid growth, and then the differential diagnosis becomes, well, is this a grade 3 endometrioid carcinoma or a dedifferentiated endometrial carcinoma? And, you know, granted, there might be some semantics here because treatment regimens are generally going to be roughly the same. Although I would argue that dedifferentiated carcinoma is probably more aggressive than grade 3, although I don't have any evidence to base that off of other than I know dedifferentiated carcinoma patients do not do very well. But this is a tough differential diagnosis. However, I would like to just offer up that really undifferentiated and dedifferentiated carcinomas are really only hard if you don't think about them. So think about them. Think about them a lot. Always make it a practice to put in your differential diagnosis of high-grade cancers, undiff, dediff. Now, general features of them, undifferentiated carcinoma, that's going to be really the big one that's going to have the biggest differential diagnosis. That's going to be relatively small monomorphic cells. The best feature is going to be that they're discohesive, but then again, that's also a tricky feature because it should make you think of many other tumors like metastatic melanoma and other tumors that can metastasize to the endometrium. Serous carcinoma can be discohesive. That's why it spreads all over the place just from little sticks in the fallopian tube, right? Do know that undifferentiated carcinoma can have little pockets of focal squamous metaplasia. That doesn't make them not undifferentiated carcinoma. They're still undiff. The thought there is that, well, maybe these are actually just really, really, really poorly differentiated endometrioid carcinomas, and I think there may be something to that. These tumors are going to completely lack other uterine or features of other uterine tumors. So they're not going to have glands. They're not going to have clear cytoplasm. They're not going to have mucinous differentiation. Things that you can see with other endometrial carcinomas, undifferentiated carcinoma should not have. And then finally, I really think that I'm on the tail of an undifferentiated carcinoma when none of my stains work. So when you're ordering a staining panel and everything's coming back negative, undifferentiated carcinoma could be the answer. Now, dedifferentiated carcinoma, on the other hand, really is tricky for grade 3 endometrioid. I think is probably the most difficult diagnosis there to differentiate. So what a D-diff is going to have is exactly the way it's named. There's going to be a well-differentiated component that de-differentiates into what looks exactly like an undifferentiated carcinoma. So I like to call these guys aggressively biphasic. They take no middle ground. They'll go from low-grade endometrioid carcinoma to sheets of malignant heinous death cancer at the snap of a finger. And you would look at it and go, well, gee, if I just had this, it would be undifferentiated carcinoma. And that's when the light bulb should go off and you say, oh, this could be a D-diff. And the immunoprofile in a lot of these cases is actually component dependent. And that can lead to some really interesting immunostaining, but can be very helpful in the diagnosis. So when we're looking at an undifferentiated carcinoma or the undifferentiated component of a dedifferentiated carcinoma, this is really where you flex your differential diagnosis muscle, right? You've got to rule out things like lymphomas and melanomas and sarcomas, neuroendocrine carcinomas, endometrial stromal sarcoma, metastasis. Anything and everything that can go wrong with the endometrium, basically you've got to rule out. And so there's a huge staining panel that you could probably get into and probably will get into in one of these cases, and know that most of them are going to come back negative. Now, some of the most important stains are going to be the ones that are traditionally positive in endometrial carcinomas. That's going to be stains like PAX8, E-cadherin, ER-PR. If you start to get positivity for those stains, then you should really reconsider your diagnosis of an undifferentiated component. Because that's actually immunohistochemical evidence of differentiation, is the fact that they still have hormone receptors or they're still PAX8 positive, because undifferentiated components often lose reactivity for these markers. So keep that in mind. You're not allowed to really have staining for that and still confidently call this an undifferentiated component. So then you'd say, well, what does work, right? Well, you can get some very rare staining with pan-cytokeratin, somewhat less rare staining with CK18 and EMA. And interestingly enough, about half of these tumors are mismatch repair deficient, which also I think is probably supporting evidence that they're endometrioid in nature. Well, and D-diff usually comes from low-grade endometrioid, so I think that's evidence as well. There are some molecular signatures that you can look for in BRG1 and INI1, and P53 can be mutant or null in the D-differentiated component, and that shouldn't make you not make the diagnosis, but that's also not that common, right? So, know that you can use P53, but be careful around P53. And so if we go back to this case that I showed you to kick everything off, you'll see that the well-differentiated glandular component is P53 wild type, and then the poorly differentiated or undifferentiated component is mutant for P53, which is a nice staining pattern. And mismatch repair staining in this case shows you that MSH6 on the left is retained in all of the tumor. However, on the right, PMS2 is lost, and that means that MLH1 was probably lost. So this is a mismatch repair deficient tumor, and that actually is somewhat supportive of an undifferentiated or dedifferentiated carcinoma. So that's a nice finding to help kind of back up your finding of saying, well, hey, this is a dedifferentiated carcinoma and not a grade 3 endometrioid carcinoma. Here's another example of one of these tumors, and you can see that this is just a sheet of cells with absolutely no defining morphologic characteristics, just small blue cells packed throughout. I mean, for what this could be a picture of a lymph node, right, with lymphoma in it, for all you guys know. And if you go down and you take a closer look, you've got these small cells predominantly composed of nucleus with very scanty cytoplasm that's somewhat eosinophilic, and then no gland formation anywhere. It looks very discohesive. This is actually an undifferentiated carcinoma. But again, it should look exactly like a lymphoma or a melanoma metastasis to you. These tumors are often very hard to define morphologically. If you got cytokeratin staining on that tumor, which I did, you'll see that the pan-cytokeratin on the left really stains like 8 cells, right? And not that strongly. CK18 on the right shows much more robust staining. However, it's not going to stain that many cells either. So you're going to see very rare staining. But this pattern is actually supportive of a diagnosis of undifferentiated carcinoma. There's going to be very rare keratin staining in these cases. So you can use that along with maybe mismatch repair deficiency and maybe P53 abnormalities and maybe negativity for all of your traditional endometrial cancer stains to support your diagnosis of an undifferentiated carcinoma. So that's it. Those are the 6 things that I would like you to take home from this little talk. Again, if you see a biopsy with invasion on it, don't call it. Think about APA first. If you have a lot of nuclear atypia in a sample, order your P53 and don't just automatically bump your FIGO grade. If you're struggling to make a small focus of glandular crowding in adenocarcinoma, don't worry. Everybody else has trouble with that. Just develop your own criteria and stick to it. And know that there's somebody out there that will probably agree with you. Don't despair if you have a solid high-grade tumor. Call your friends and use your handy panel of stains. If you see a funny staining pattern or presentation of a tumor, don't ever forget a metastasis. And then finally, if you're working up a high-grade tumor, like number 4, don't forget about undifferentiated, dedifferentiated carcinoma, and you'll never miss that diagnosis. So I thank you for your attention, and I'd be happy to answer any questions.
Thank you so much, Dr. Quick. This was a really brilliant presentation, and you have shown 6 examples of very interesting cases and how to approach the differential diagnosis. I can see a few questions online, and first of all, here's this question from Minesh. The question is, when to use atypical mucinous glandular proliferation in DNC material?
Oh, that is a great question. I could write a lecture on just on just atypical mucinous proliferations. And so you know that you're getting ready to get an answer that's probably not going to answer your question. And I apologize for that in advance. But mucinous proliferations of the endometrium, they're tricky. When I see any kind of mucinous differentiation in the endometrium, the first thing I do is I look at the complexity of the epithelium, right? And so if you have a single strip of columnar type epithelium, I call that simple mucinous metaplasia. I make a note that it's likely benign. However, the patient should be followed. And the rationale for that is that those simple mucinous metaplasias are often associated with later on worse mucinous metaplasias, and they can have KRAS mutations and things like that. But that's not really the question. The question is, what about these complex mucinous lesions? And I think that there's a couple of ways to define complexity. First off, you could have cribriforming complexity. In my opinion, you should treat those mucinous proliferations at architecturally the same as you would try to diagnose an EIN or an atypical hyperplasia. In other words, if your mucinous proliferation is demarcated, so cytologic demarcation, if that proliferation is about 1 millimeter in size, and if the background endometrium looks different, again, cytologic demarcation, I would tend to favor a diagnosis of a mucinous EIN or atypical hyperplasia in a case like that. Now, the thing that I haven't talked about and that I'm kind of dreading talking about is what we call the papillary proliferations of the endometrium. And there's been a couple of papers. Dr. Hart had a great article. Dr. Young had an article that talked about these papillary mucinous proliferations of the endometrium. And I bet this is what you're asking about. These things are very difficult because follow-up studies have shown that they're not always that malignant. In other words, they may not be malignant at all, but they can be architecturally complex. They can have papillae that grow into the glands. So the way to deal with these is to look at the number of branches that these lesions have. If it's just primary branching, then that is probably a benign lesion, and I diagnose those as papillary mucinous proliferation, C comment, and then I say that there's this mucinous proliferation. However, it's not that architecturally complex. There's a low risk of progression, and that the patient should just be followed with surveillance. If there is secondary and tertiary branching of your papillae in these mucinous proliferations, those lesions have been shown to be somewhat more aggressive and should be considered kind of equivalent, again, with a mucinous EIN or atypical hyperplasia. So those patients are going to at least need additional sampling, but they're definitely going to need follow-up. And maybe if they're past their childbearing years, consideration of a hysterectomy would not be a bad thing in these patients, because those lesions are often associated with underlying mutations, and it's best not to leave them alone. So I hope I answered that question. That's a good one because those lesions are very difficult, and I'm sure everybody wrestles with them just like I do.
Thank you. The next question is from Mary Matthew. How to diagnose carcinoma at the lower uterine segment, which has features of both endometrial and endocervical carcinoma?
Another good one. And yeah, so this was one of the cases that I almost put into this lecture, but I was afraid I was going to get too long because I think that this should always be in your differential diagnosis. So Mary, I'm glad you asked about that. Whenever I see a cervical biopsy with something that looks endometrioid or an endometrial biopsy with something that could be endocervical, I always want to make sure that I'm not dealing with the other site, right? Or the cervix to the endometrium. So this is a perfect example of that, and you got to ask this question. I think the easiest thing to do is to go to the chart first, right? Because that's quick and it's free, and you can look. And if the patient is young and if the patient is thin, I would have a very high index of suspicion for cervical primaries. If the patient is middle-aged to postmenopausal, if they're obese, I would favor endometrial primaries. Now, that is not 100%, and I don't use that in lieu of immunostaining. However, sometimes the answer, as I said, in the case of metastasis, is just staring you right in the face when you look at the chart. So always start there. I think the next step that you can do is P16 staining and hormone staining. I like PR. I found that PR is often negative in most cervical lesions. It should be negative, or at least only weekly positive in cervical lesions. Whereas a low-grade endometrial cancer should have robust PR staining. That doesn't help you in the case of a high-grade cancer. P16 doesn't help either because, as I said before, P16 can be positive in anything that's high-grade. So the differential becomes much more difficult when you're dealing with a high-grade lesion. I think in high-grade lesions, the gold standard, and actually the gold standard for low-grade too, is going to be ISH for HPV. It's not everybody has access to that, but you can send out for it. But if you have ISH for HPV and you have HPV within the lesion, the chances of it being a cervical primary are much more high than it being endometrial. So I usually use that progression. I start with a chart review. I go to my basic stains, P16, PR, and that works great for low-grade lesions. And then some low-grade lesions and almost all of the high-grade lesions, I'm going to also do HPV-ish. Just to make sure that I'm not missing something there. Some people might say, well, what about Vimentin? I know this is one of the very few times you can actually use Vimentin and it be useful, other than being a positive control. So yeah, you can use Vimentin, although Vimentin staining in endometrium can be patchy, and you can see focal positivity in cervical lesions. So just know that Vimentin might be focally lying to you when you look at it. So be careful there.
Thank you, Dr. Quick. Here is another question. This is from Kalyani. How does INI1 help in dedifferentiated versus undifferentiated?
I don't think that it can help you discern a dedifferentiated from an undifferentiated carcinoma. It will, or it can occasionally identify a case of undiff, d-diff, if your immunostains aren't helping. Now, that being said, that's just a mutation that has been described in a good number of these tumors. I haven't used INI1 diagnostically for this carcinoma yet. I haven't had to. I think if you have a wide enough staining panel and you confidently rule out all of the other sources of tumor that it could be, that you don't necessarily need it. But if you do have INI1 loss, then you could be looking at an undiff d-diff. And I think that that's kind of the take home there, is that this is just yet another tool in your toolbox for identifying one of these cancers. That being said, you certainly see that mutation in other tumors. And so again, using it in isolation, not a good idea. You want to use that in conjunction with your morphology and with all of the different stains that you're going to use to help whittle down your differential diagnosis. So yeah, it's a good new finding with these tumors, and it could be somewhat helpful. So if your back's up against a wall, try it out and let me know how it works.
Thank you. There is another question that's from Han. Morphologically, mucinous metaplasia, can it be differentiated from mucinous carcinoma on morphology with distinct features?
So yeah, that's a really good question, and what to do with metaplasias. Really, you can take that and you can expand on it too. You can actually expand mucinous to just basically say any metaplasia of the endometrium could actually could be a lesion, right? Could be an EIN, could be a carcinoma. Now, cytologically, there's not much you can do. No, that cytology doesn't help. Usually, they tend to be bland. So I want you to look at the architecture whenever you're faced with a case of a metaplasia. Mucin is very common. So a mucinous metaplasia, for example, look at the overall architecture. Go to low power. If the area of mucinous metaplasia that you're seeing is complex, and if it stands out from the background endometrium, I would argue that you're at least dealing with a mucinous EIN or a mucinous adenocarcinoma. In my mind, I like to use the mental exercise of, okay, if this wasn't mucinous epithelium, if this was just traditional endometrioid type epithelium, with this complexity, would I worry about this lesion? Would I want to call it an atypical hyperplasia? And if my answer to that question is yes, then often I will take that lesion and I will diagnose it as a mucinous EIN or a mucinous atypical hyperplasia. If my answer to that question is no, it's not that complex enough, then I might give it a descriptive diagnosis like atypical mucinous proliferation or atypical glandular proliferation. And then in my comment, I'm going to defend myself, right? I'm going to say, look, there's some mucinous glands, they're somewhat atypical. They don't reach the threshold for what I would want to call an EIN. However, I'm worried about this, and you should bring the patient back in about 3 months for additional sampling. Usually when I recommend a timeline like that, I also add in parentheses to allow for endometrial healing, because if your clinicians are like mine, if you don't say, hey, wait 3 months to let everything kind of heal and let everything regenerate, what you get is a sample the next week, because they bring the person back. They're saying, oh, a week's better than 3 months. We'll bring them back tomorrow and get a biopsy. And you know what that's going to look like. It's going to be blood, fibrin breakdown. It's going to look horrible, and it's not going to help at all. So I tell them to wait 3 months, take another sample. Let's see if anything is there. And then we can work from there. So, sometimes you have to approach these descriptively. And I'm not going to lie, that's the tack that I take most times when I'm not confident in my diagnosis. And I don't think it hurts to be descriptive, and it certainly doesn't hurt to call your clinician and say, look, I got a tough lesion here, and we're going to need to work together on this patient to make sure we get the right treatment for them.
Thanks. There is another question that's from Azaz Khan. If only MLH1 is lost, can we call it MMR deficiency?
If one is lost, it depends on which one. So, as
MLH1. The question is
if
about MLH1.
Oh, okay. Sorry, I just heard one. Yeah. So if MLH1 is lost, if MLH1 is lost, then PMS2 is almost always going to be lost. And I think what you're looking at is an MMR deficient tumor. When I'm working with these diagnostically, I only use the submissive part of the pair. So I'm only going to use PMS2 and MSH6 to diagnose that. But yeah, I think if MLH1 is lost, you're definitely dealing with I can't say definitely ever, right? But 99% of the time, you're dealing with a mismatch repair deficient tumor. Now, it's not necessarily a Lynch syndrome patient, right? Because that is usually due to promoter hypermethylation in the setting of endometrial cancer. So you would need further studies to make sure that they don't have Lynch syndrome. But yes, if I see MLH1 loss, that's a pretty good sign that you're dealing with an MMRD tumor.
The next question is also related. It's from Ariam. Can you use MMR immunostain loss to differentiate ovarian and endometrioid to determine primary?
So that's a really good and tricky question. I would say that I would not do that. It's not because you can't do it. Certainly, I think that there's more endometrial tumors that are mismatch repair deficient than ovarian tumors, but there's enough ovarian tumors that are mismatch repair deficient to where I don't think that having deficiency would actually indicate a site of origin. This is a really tough question. It frequently comes up when we talk about staging, and you have endometrial and ovarian disease, and you say, okay, is this synchronous primaries? Is this a metastasis? What's going on? And in my mind, I don't think that we've come up with an answer for that yet. I know that there's been studies that have come out recently that show clonality between ovarian and endometrial tumors. However, then again, sometimes that just doesn't fit, and it looks like that they're probably still synchronous primaries. So I'm not sure about ever being able to confidently identify the site of origin in these tumors. And sometimes I think it's okay to say, you know what, I can't tell you if this is a metastasis versus synchronous primaries. There are lots of tools in our toolbox that we can use to kind of point one way or the other. Certainly immunostains, some molecular findings, mismatch repair has been offered up, Vimentin staining has been offered up as potential things. And certainly they're worth trying. And you also want to pair that with your histology, right? I mean, if you've got a big, bulky, necrotic ovarian tumor and a little bitty superficial endometrial tumor, I would really be kind of concerned about
metastasis in a case like that. And conversely, if you have a very deeply invasive endometrial cancer and then surface deposits of endometrioid carcinoma on the ovary, I would say that that's probably a metastasis as well. So I love your question because I don't think that I can answer it, at least yet. I need somebody that's smarter than me out there to come up with a good way to answer that question for all of us, and then we won't have to worry about it anymore. So I wouldn't trust mismatch repair staining for that scenario just yet. But if you did get discordant staining, I think that you could use that as evidence to say that the two tumors aren't related. So yes and no. Sorry for for taking a wishy-washy answer.
Thank you. The next question is a little different. This is from Jayati Datta Mukherjee. Endometrial serous carcinoma versus grade 3 endometrial carcinoma. Would you use P16 given the fact that WT1 can be patchy in endometrial serous carcinoma?
Yeah, that is a tough question, and I'm glad you asked about that because I like to bring that up again and again to my friends and colleagues. I wouldn't use P16. I've seen enough strong P16 staining in high grade cancers, basically anywhere, right? To not have a very high level of trust for that stain. I think there are better options. They don't work every time, and certainly the bad answer here, the easy way out is to say there are going to be cases where you can't differentiate serous from high grade endometrioid. And unfortunately, that's the case. But I think there are ways that you can get around it, especially if we use the TCGA data. We know that grade 3 endometrioids have more P10 loss. Serous almost never has P10 loss. So I like to use P10 in that scenario. Serous can have mismatch repair deficiencies, but it's not common at all. And so I think that using mismatch repair deficiency could be helpful. Certainly, PAX2 loss has been something that's been associated with endometrioid carcinomas, not so much with serous carcinomas. So there are a few stains out there that I like better than P16, just because it's like you said, you get overlap in these stains. And so how can you tell all the time? And I don't think you can. I often liken it to a seesaw or a teeter-totter, and you've got stains and they might stack up on one side versus the other. And sometimes the best you can do is say, well, we have more evidence for endometrioid carcinoma here than we do have for serous carcinoma. So I'm going to say high-grade Mullerian carcinoma favor high-grade endometrioid, and that might be the best you can do. And that's okay. That's okay, because in the end, the treatment for the patient is actually probably going to be the same chemotherapy and probably going to be the same surgery. So if you can't nail it down, it's not the end of the world. Certainly, we always want to try to make the most accurate diagnosis we can. But yeah, some stains, they just don't help. Now, there are molecular assays you can do, and you can look for mutations in things like KRAS and P10 and mTOR, and they're more associated with endometrioids. Sometimes that may be helpful, but on a daily basis, I'm not going to go that far. Now, there is hope on the horizon. You could say, well, what about TCGA stuff? You just brought that up. I do think that eventually what we're going to be doing is molecularly classifying these. And the nice thing about that is it's going to remove this issue, is that, we say, okay, well, I can't tell if this is serous or high grade endometrioid, but we'll say, you know what, it doesn't matter because this is a P53 mutant tumor, and we know that it's in this group in the TCGA molecular classification. And so that actually could give us a little bit of ease in our diagnosis. So morphologically, can you answer that question? Not every time, but at least molecularly in the future, I think we're going to have some success there in classifying these tumors, at least based on their prognosis and their survival, their potential survival. So great question. Tough. You guys are asking really hard questions. I like it.
Thank you so much, Dr. Quick. I think we have come to the end of the QA session, and it was really an amazing session. And you have realized that I think this is such a topic which is everybody is facing these tough situations every day in diagnosing challenging cases. And I'm sure Dr. Quick has been able to answer so many questions from the viewers. And Dr. Quick, you would be so happy to hear that you have several hundred viewers from so many different countries across the world. And I personally could keep track of at least 40 countries that
Wow.
people have joined, and I will name a few. There were viewers from Brunei, as far as Kazakhstan. Someone from Said from Iran joined in. Iran and Bidgol, that is a city in Iran, I have heard for the first time today. People have joined from Nepal, Israel, Peru, Romania, Poland, Dominican Republic, Sudan, Algeria, Jordan, El Salvador, Malaysia, Nepal, to name a few. And of course, we had viewers from US as well as from India. Thanks to all our viewers always for supporting us and attending our lectures. And please don't forget to follow and like our Facebook page, that is Patcast, and also subscribe to our YouTube channel with the same name. And we also have an uh, newsletter, so you can subscribe to our newsletter so that you can stay updated with all the upcoming lectures. We always appreciate your support. And our next lecture is coming up very soon. That's on Friday, August 28 at 8 a.m. Eastern time. And that would be a lecture on placental pathology. The title of the talk is Products of Conception, What Not to Miss. And the speaker is from Massachusetts General Hospital at Harvard University, Dr. Wanda Toros, who is an assistant professor of pathology there. So hope to see you all then. And thank you so much, Dr. Quick, again, for this excellent lecture.
Thank you. It was my pleasure.